We're going to start this morning with vascular surgery, arterial aneurysms, and arterial diseases, given by Dr. Tina Desai. She's the Clinical Associate Professor of Surgery at Stanford University. Please welcome Dr. Desai.
It's actually warm up here. Good morning. For the next couple lectures, actually this one and the one after, we're going to do sort of a whirlwind tour of vascular surgery for the purposes of your board review. The first session we'll talk about arterial aneurysms and arterial disease. This is my disclosure statement. I have nothing to disclose. So these are, I think you guys have the slides in your binders. So we're going to first start off talking about aneurysms and the general objectives. We're going to talk about what an aneurysm is, define the risks of an aneurysm, talk a little bit about the types of repair that are available, and then some of the complications of the repair. And then at the end, we'll talk a little bit about aortic dissection as well as mesenteric ischemia. So we'll start off with the question. 68-year-old woman had an abdominal ultrasound, which demonstrated a 4.3 centimeter infrarenal abdominal aortic aneurysm. 1 year ago, the maximum diameter of her aneurysm was 3.9 centimeters by ultrasound. What is the appropriate management? The correct answer is E, a repeat ultrasound. This is an aneurysm that's still relatively small but has grown, and so it's appropriate to continue to follow it carefully. What is an aneurysm? An aneurysm is a focal increase in diameter of a blood vessel compared to normal. The normal aortic diameter in the infrarenal aorta is approximately 2 centimeters, although this can be variable. An aneurysm is defined as double that or greater than 3 centimeter diameter. The big issue with aortic aneurysms is rupture, and one of the important pathophysiologic equations to remember just for the purposes of the boards, although we know now that this is a much more complicated process than just wall tension, but the issue of wall tension being related to the pressure as well as the radius of the aorta and the wall thickness is an important concept. This is just a more complicated physics type diagram that demonstrates the relationship between the radius and the tension in the wall, where if you increase the radius by 3 times, it actually, based on the variables, increases the wall tension 12 times. So the bigger an aneurysm gets, and especially at the larger sizes, the higher the risk of rupture. Aneurysms tend to occur in men. They tend to occur in men over the age of 60 overall. The most important risk factor for aneurysms is smoking, followed by a family history, age, diabetes, and female gender are actually negative risk factors, and aneurysms are not associated with these particular groups. Most aneurysms, greater than 90%, occur in the infrarenal aorta, and they're associated iliac aneurysms in somewhere around 15-20%. The rupture risk, as I mentioned before, varies with size. In particular, the average growth of an aneurysm is about 10% per year, and the rupture risk increases dramatically after 6 centimeters. So this is why we tend to recommend repair of aneurysms in the range of 5 to 5.5 centimeters for men. Diagnosing aneurysms, the majority are asymptomatic, so it's important for us to think about aneurysms in patients that are high risk in the population we talked about. Physical exam is a pretty poor way to diagnose these aneurysms, especially in the United States with our current population of patients. Many of them are overweight or obese. It's hard to pick one of these up by examination alone. Ultrasound is a very good screening test, an initial test for looking for aneurysms. There are some limitations. It's limited by the technician doing the study and by the body habitus of the patient as well as bowel gas, but overall it is the initial screening test of choice if you suspect someone to have an aneurysm. CT scan is a little better in terms of defining the anatomy once an aneurysm has been diagnosed, and we tend to use this study when the aneurysm approaches sizes of where we might be considering repairing it, so greater than 4.5 centimeters, as well as to exclude rupture in some patients if you're suspecting rupture based on symptoms. And then also if someone presents with abdominal pain, it's useful in terms of ruling out other pathologies that might be causing their abdominal pain. So some of the key concepts in terms of elective repair, we tend to repair aneurysms that are greater than 5.5 centimeters in men. This size cutoff may be a little bit lower for women whose arteries tend to be smaller, so their aortas may be defined as aneurysmal at a slightly smaller size than a man. So the general indications for repair are growth to greater than 5.5 centimeters, rapid expansion, and by that, the expected rate of expansion of an aneurysm is about 0.5 centimeters per year. So if the rate of expansion is greater than this, we might recommend repair in any patient that is symptomatic, regardless of the size of their aneurysm. In women, our size cutoff is generally closer to 5 centimeters. So one of the big questions that comes up is what kind of workup do people need before an elective aneurysm repair? And this just outlines some of the cardiac workup that's necessary. In general, we recommend stress test if they have 3 or more cardiovascular risk factors that are listed here, or if you don't really know their functional status and you can't define it very well, or if they have poor functional status. The cardiac complications are the most common complications after aneurysm repair, and so this is an important question that often comes up. Another question that comes up is consideration of patients that actually have known coronary disease, or you define that they have coronary disease in the process of the workup. So again, listed here are some of the indications for doing revascularization prior to an aneurysm repair. In general, it's somebody that either has symptomatic coronary disease or has severe left main or 3-vessel disease. And then this question used to come up a lot in terms of whether when you can do an elective aneurysm repair after a coronary intervention. This is less important in patients that can undergo endovascular repair because we're much more willing to do those procedures under when the patient is taking Plavix. But with open repair, we generally like to stop the Plavix because of the bleeding risks. And so with a bare metal stent, you want to continue the Plavix for at least a month. With drug-eluting stents now, the recommendations are 1 year. So depending on the aneurysm size, you want to defer the procedure until you can hold the Plavix. Again, these considerations are not as important with endovascular repair, which we can perform while the patient is taking Plavix. So we'll have another question. A 75-year-old man was taken to the emergency department after an episode of syncope. He complains of abdominal pain and is noted to have a pulsatile abdominal mass. His blood pressure is 85/40. However, he is awake and conversant. What is the most appropriate initial management? A, resuscitation with fluid and blood. B, ultrasound to diagnose AAA rupture. C, CT scan of the abdomen and pelvis. D, transfer to the OR for emergent surgery. Or E, diagnostic arteriography. So the correct answer in this patient is C, CT scan of the abdomen and pelvis. We suspect this patient has a rupture, but he is still maintaining his mental status. And in the era of rapid CT scans, a CT scanner can give us a rapid diagnosis, and it can also help us to guide treatment, especially if you have capability to do endovascular repair in some of these patients. So this is just a diagram of a open repair for an abdominal aortic aneurysm. We'll talk a little bit about repair now. Open repair involves dissection of the aorta and suturing of a graft to the aorta. Some of the principles of open repair include what kind of exposure you're going to do, which can be transabdominal or retroperitoneal. In the era where we don't do a lot of dissection of the aorta open anymore, the transabdominal approach is probably the most rapid and expedient. Where you want to, you have to consider where you're going to put your clamp. And in general, for elective repairs, you want to put the clamp close to the renal arteries, below the renal arteries. You don't want to go too far down on the aorta, even if you have a neck, because there are risks of future aneurysm formation below the renal arteries. If you need to, it's okay to divide the left renal vein. You want to take this close to the vena cava to preserve collaterals. Anticoagulation is important when you clamp the aorta. And then the type of graft really doesn't matter. You want to repair the part of the aorta that's abnormal and aneurysmal, but preserve any normal vessels, so you can do a tube graft or a bifurcated graft, depending on the anatomy. And then the final sort of principles are to close the sac of the aneurysm around the graft, as well as retroperitoneal tissue, if possible, over the graft, to try to isolate the aorta from the intra-abdominal contents. Who do we want to reimplant the inferior mesenteric artery in? Sometimes the inferior mesenteric artery will be patent in these patients. Generally, you want to reimplant the inferior mesenteric artery if it is patent and the blood flow through it is poor. If you have very good back bleeding through the inferior mesenteric artery, then typically that suggests good collateral circulation. Here are some of the circumstances where you would want to consider reimplanting it if you know that the patient has other mesenteric disease. If you've noted on CT scan that he has large collaterals, such as a meandering mesenteric artery. If patients have had prior colon resection, their collaterals won't be well preserved. If there's poor back bleeding, as we talked about, if the vessel's patent but the back bleeding's poor. And finally, if they have had previous operations where you suspect the pelvic circulation is not well preserved. This is just a CT scan of a large meandering mesenteric artery. You can see, let's see if I can get my right there with a big IMA. Let me move this thing out of the way. So our question talked a little bit about rupture, and we can discuss that for a few minutes quickly. So the signs and symptoms of rupture, the classic signs, pain, hypotension, pulsatile abdominal mass, are present in less than 50%. So you really have to have a high index of suspicion in an elderly patient who has atherosclerotic disease, who's a smoker. You want to consider this diagnosis. They come in with even atypical abdominal pain symptoms. There are a variety of syndromes that are included in the differential diagnosis. The bottom line is that a CT scan is the key to diagnosing and helping you plan treatment for these patients. Less than 15% of patients that have a ruptured aneurysm and make it to the hospital die within 2 hours. So this does give you enough time to get a CT scan and to get the patient to the operating room, but not the luxury of time to sit around and wait and do an extensive diagnostic workup, excuse me. So initial management, CT scan we talked about. You want to keep their blood pressure on the low normal side as long as they are mentating and preserving organ perfusion, such as urine output. The principle is we want to try to avoid aggressive fluid resuscitation. We call this permissive hypotension. There are patients that present with symptomatic aneurysms but not ruptured aneurysms on CT scan. These are sort of a separate group that we consider. And the general principle is for a large aneurysm that's greater than 5 centimeters, you want to go ahead and admit them and repair them within that hospital admission. For someone with a smaller aneurysm, it's probably important to look for other causes of pain if the aneurysm doesn't have any atypical morphology or other reason that you might suspect symptoms from it. So in terms of open repair, many of these ruptured aneurysms in larger institutions are now managed endovascularly. But open repair is sort of a classic board's question they ask about when you're doing a ruptured aneurysm repair. So the principles are you want to prep and drape the patient before you induce anesthesia because the anesthetic itself can make them severely hypotensive and crash hemodynamically. Proximal control, the safest and most rapid place to get proximal control is in the supraceliac aorta at the diaphragmatic hiatus through a transperitoneal incision. In reality, sometimes we'll get infrarenal control if we're able to, but this is sort of the safest and sort of classic answer to the question. Other techniques have been described, such as putting a balloon in, which can be problematic, especially if you don't have a lot of endovascular imaging capabilities in the operating room. Thoracotomy can occasionally be necessary. If you can get to the supraceliac aorta, which you should be able to in most patients, this is usually not necessarily. I think retroperitoneal exposure can be very difficult in these situations, especially if you don't have a lot of exposure to that type of dissection. Distal control, you can put clamps on the iliacs or you can balloon occlude them from the inside of the aneurysm, so you don't need to waste a lot of time dissecting that out. Heparinization is sort of plus minus. We don't use a full dose typically, especially if the patient has bled a lot, but this really depends on the patient's state. And then you want to think about passing some Fogarty catheters if you don't use heparin distally because you can form clot after the repair. And then in patients that are, the last sort of point was if they're, you can consider leaving their abdomen open depending on how much hematoma they have, what kind of fluid losses they've had, what kind of bowel and tissue edema they have after the operation. These patients can be at high risk for compartment syndrome. So next question, an 80-year-old man was treated with an endovascular repair for a 6.2 centimeter aneurysm 4 years ago. CT examination demonstrated that the aneurysm enlarged to 7 centimeters with contrast entering the sac around the proximal seal zone. What type of endoleak is causing his aneurysm enlargement? A, type 1, B, type 2, C, type 3, D, type 4, E, type 5. So the correct answer to this is A, and in a few slides we'll go over the different types of endoleaks, but these are things that you will encounter on CAT scans you get for other purposes, even if you're not in vascular surgery these days, so it's useful to know about endovascular repair and its complications. This is an image of a patient with an aneurysm on your left, and then the aneurysm with a stent graft repairing it on the right. So endovascular repair has been around now since the early, really in its experimental phases since the early 90s and approved since 1999. It's done through 1 or 2 small incisions, typically in the groins, although nowadays many of us do these percutaneously as well, so just because you don't see an incision doesn't mean the patient didn't have a repair. A variety of different types of grafts are available for repair of aneurysms. The principle is that the stent portions of the stent grafts fix in the artery above and below the aneurysm, so the aorta above, and then typically the iliac arteries below. So you have to have appropriate anatomy to perform this type of repair. This diagram just shows some of the anatomic requirements. You want a good proximal neck in terms of length and diameter. You don't want a lot of angulation because this puts undue forces on the stent. Thrombus in the neck makes this fixation difficult, so this should be minimal. And then you need big enough access vessels to get the stent graft devices to their location, although the sizes of these stent grafts are decreasing as they get developed. So in talking to patients, you have to discuss open versus endovascular repair of aneurysms with patients and making this decision. Advantages and disadvantages listed on this chart. The main principles are that the open repair is bigger stress and potentially bigger risk up front. With a longer recovery time, more blood loss. The advantage of the open repair is that there is less follow-ups. We used to say we didn't have to get any further imaging for these patients, but I think most of us will do some imaging at 5 or 10 years to look for other aneurysm formation, even in the open repair patients. Endovascular repair has a lower mortality up front during the operation with much faster recovery, probably useful for more elderly, more debilitated patients, less blood loss. The disadvantages are that we do not remove the aneurysm, and the fixation is based on a device and a stent fixing to the wall of the aorta, not our full thickness sutures. So they do need long-term follow-up. There are definitely anatomic exclusions, although this is technology is getting better and better. And then the sort of Achilles heel are this concept of endoleaks that occur after aneurysms are repaired this way, which we'll talk about in a minute. These are some of the trial results, which basically show that in the short run, endovascular repair is probably better tolerated. In the long run, the mortality and is really not affected and is pretty much the same between open and endovascular repair. Ruptured aneurysms. We can do endovascular repair for ruptured aneurysms. CT scans are an important part of the pre-op workup. And then you basically need a OR system that allows you to do this, that the nurses and the people in your operating room know what equipment they need and how to get this done. Basically, you can start your procedure under local if the patient is moderately stable. You can do your groin cut downs, which we tend to do. They talk about a percutaneous sheath, which is a possibility, but I usually tend to do a quick cut down because it doesn't take that long to get to the femoral arteries. And then you control first with a balloon. You need to support this with a sheath, and you need to be able to get a stiff wire in. And then place your graft. There's controversy. In the early phases, we used to put aorto-uniiliac grafts in almost everyone for ruptured aneurysms and then do a fem-fem and exclude the other iliac artery because we thought it was quicker. In this day and age, I think in most patients you can get a bifurcated system in, so there's no hard and fast rule about this. And then the other big caveat about ruptured aneurysms being repaired endovascularly is that depending on the amount of hematoma and blood loss, reperfusion and abdominal compartment syndrome continues to be a problem, and there's a very high mortality for this as a missed diagnosis. So if the patient has a tense abdomen at the end of the procedure, you should consider doing just a decompressive laparotomy, even though you do an endovascular repair. So let's talk a little bit about endoleaks. Endoleaks are blood flow around the stent graft into the aneurysm sac. Typically, they're asymptomatic. This is not bleeding. This is not rupture. When any medical doctor or anyone calls you about this, this is not a cause of anemia in a patient. The big problem with endoleaks is that they can repressurize the aneurysm. And if the aneurysm gets repressurized, there is some risk that aneurysm can still rupture. There's probably 1 in 4, 1 in 5 chance of an endoleak occurring over 10 years follow-up of an endovascular aneurysm. And most of these endoleaks can be treated with minimally invasive procedures as well. So this is just a diagrammatic representation of the types of endoleaks. Type 1 endoleaks and type 3 endoleaks are probably the most important from the perspective of being able to cause problems in aneurysms. And these are the types that need to be fixed. Type 1 endoleaks are attachment site endoleaks, either proximal or distal. Type 3 endoleaks are failures at junction points between stents or failures of the device where there's actually a break in the device itself. Type 2 endoleaks are from branch vessels, and they're typically not problematic unless they're associated with an increasing aortic sac size. Type 4 endoleaks tend not to occur very frequently anymore. They used to be related to some of the thinner fabrics that were used with early generation stent grafts. And then a new type 5 endoleak has been defined, which is really not an endoleak. It's a situation where you don't see a leak, but the sac is pressurized or growing, and this is considered endotension. We don't really know what this is, and I think there's pretty poor understanding, but the problem is that when that sac is growing, you feel compelled to do something about it. Again, just a summary of the types of endoleaks and what you want to do about them. The bottom line is that the 1 in 3 endoleaks are the ones that have to be repaired. So these are just options of how these endoleaks can be repaired. For type 1 endoleaks, they're a failure of the fixation sites, so you can put a cuff proximal, potentially extend distally. Type 3 endoleaks, again, can be treated with reinforcing stent grafts or relining of stent grafts. Type 2 endoleaks are probably the most difficult to treat just because even if you are able to occlude the branch vessel, you think it's coming from other branch vessels, and other types of these endoleaks tend to develop over time. And I think that's really it. The type 5 endoleaks, again, are difficult to treat because you can't really define where that pressure is coming from. Often we'll try to reline the graft before we embark on some big open repair where we have to explant the thing. So question, a 65-year-old man develops bloody diarrhea 2 days after undergoing an open repair of his ruptured abdominal aortic aneurysm. What is the most appropriate immediate management? A, intravenous antibiotics and bowel rest. B, emergency exploratory laparotomy. C, sigmoidoscopy. D, transfusion of packed red blood cells. E, total parenteral nutrition. The correct answer is C, sigmoidoscopy. So the dreaded complication of colonic ischemia after abdominal aortic aneurysm. This is really an uncommon complication with elective repair, but can happen, especially after ruptured aneurysm repair. More common after open than endovascular. It can result from interruption of primary or collateral flow, or in some rarer cases, atheroembolization, which may occur more commonly with endovascular repair where we're passing wires across the aorta and iliac vessels. Some of the contributing factors include hypotension during the case, a large retroperitoneal hematoma, and bowel distension. It may be occur in the setting of celiac or SMA stenosis, where adding the aneurysm repair and potentially occluding the inferior mesenteric artery can contribute to this ischemia. This is important consideration in a patient who had an enlarged IMA preoperatively, or in someone who'd had previous interruption of pelvic circulation. The typical clinical scenario is bloody diarrhea about 48 hours after surgery, and a bedside sigmoidoscopy can make the diagnosis. The general treatment is exploration and colectomy for a hemodynamically unstable patient or a patient who has full thickness necrosis. In milder cases where there's non-transmural necrosis, you can use non-operative management with keeping the patient NPO, putting them on antibiotics. One of the key principles of operative treatment is to try to keep the graft covered if you've done an open repair or even endovascular when you do the colectomy. Aortoenteric fistula is a later complication of previous aneurysm repair. Primary aortoenteric fistulas are very rare. In someone who's had a previous repair and presents with GI bleeding, this is important to keep in the back of your mind. And a favorite question that appears. Diagnosis in the current era, CT should show most of these. We used to try to do endoscopy. Our endoscopers are typically not excited about doing an endoscopy when we truly are suspecting this, and the blood often makes it very difficult to see. It's really important to take the endoscopy to the fourth portion of the duodenum, as this is generally the location where that fistula occurs, and if they don't, then you won't see it. The treatment is generally to remove the graft, oversew the aorta, and do an extra anatomic bypass in an order that is appropriate for the patient's clinical scenario. So if they're unstable hemodynamically, you obviously have to go in and clamp their aorta and remove their graft first. You want to close the visceral tear, divert the intestine, and then do some maneuver to separate the GI tract from the aorta to prevent this from recurring. If that's putting some momentum, trying to close retroperitoneum, whatever you need to do. Another question. 6 months after her endovascular abdominal aortic aneurysm repair, a 71-year-old woman presents with abrupt onset of left hip and thigh pain after walking short distances. Her examination is notable for an absent left femoral pulse and a left ankle brachial index of 0.75. She has palpable right lower extremity pulses, and her right ABI is 1.1. What is the most likely etiology of her left leg pain? A, type 3 endoleak. B, occlusion of the left limb of the aortic endograft. C, distal migration of the endograft. D, left common femoral artery atherosclerotic disease. E, left superficial femoral artery embolus. The correct answer is B, occlusion of the left limb of the aortic endograft. We'll talk just for a few minutes about perioperative, intraoperative, and then later complications of endovascular aneurysm repair. Couple clinical scenarios just to go through. During the operation, the patient becomes hypotensive, especially at the end of the case when you're withdrawing your sheath. That is an indication of iliac artery injury. Typically, the injury occurs when you're passing your sheath up, but the injury is tamponaded by the device and your sheath. When you remove it, that's when the injury shows up. The treatment of this, since presumably you still have wire access across this area, is to blow up a balloon to tamponade it temporarily, and then to put a stent graft across the area of injury. The scenario of oliguria and an increased creatinine is usually an issue with contrast nephropathy. We do try to minimize the amount of contrast that we use, but when you're trying to do aortograms, this can increase pretty rapidly without you realizing it. It's important to pay attention to it, and then preventing it in a patient who is at higher risk, diabetic, patient with some elevated renal function tests to begin with hydration, and trying to minimize the contrast use is important. Claudication, as we described in our question, that occurs at some period after an endovascular repair, is typically related to limb occlusion. It's more common with some types of stent grafts than others. The options include thrombectomy in a later stent graft. This is probably a little more hairy to do early versus a fem-fem bypass if the other side is preserved. And then finally, aneurysm sac growth. At some point after the procedure, you want to look for some issue with the stent graft, either an endoleak, migration of the graft, and the treatment really depends on the scenario that you encounter in terms of where the endoleak is coming from. And then another favorite sort of board question, if you remember, is the issue of other conditions encountered when you are trying to repair an abdominal aortic aneurysm. This is obviously more an issue when you're doing an open repair and encounter some of these conditions. A non-obstructive colon cancer, if you go in to repair the aneurysm, you should just go ahead and repair the aneurysm and then resect the colon later. If you encounter a bleeding, obstructive, or perforated cancer, then you want to go ahead and treat the cancer first and repair the aneurysm later. And if you have an option later to do an endovascular repair, that may be a better option rather than going back into the abdomen. A renal or ovarian malignancy that's basically a clean lesion can be simultaneously repaired. And then you want to try to avoid cholecystectomy at the same time as an aneurysm. Don't want to communicate with the GI tract. Brief discussion of thoracic aortic aneurysms. In general, they're a higher risk of repair than abdominal aortic aneurysms, bigger complications, and the most dreaded spinal cord ischemia complication can be associated with these. We tend to repair them when they're more than 6 centimeters. That's the usual cutoff. The options include open repair, which is usually via a thoracotomy or thoracoabdominal incision, versus endovascular repair. This is a classification scheme for thoracoabdominal aneurysms shown on the upper right, varying from type 1 thoracoabdominal aneurysms, which extend from the left subclavian to the diaphragm, type 2 that extend from the left subclavian to the aortic bifurcation, type 3 from the mid-descending thoracic aorta to the bifurcation, and type 4, which occur from the diaphragm to the bifurcation. There's actually also a type 5 that extends from the mid-thoracic, not just to the level of the renal arteries as well. These tend to increase with age. The rupture risk correlates with size. The highest risk of repair is with the most extensive aneurysms. And the biggest issue is the issue of spinal cord ischemia, which can occur with open repair in up to 15% of patients, so it's an important consideration with extensive aneurysms. Endovascular repair has now been shown, as we'll talk about, to be a good option for a number of these patients. The spinal cord ischemia risks are probably a little bit lower, although not zero. Aortic dissection is a tear in the aortic wall that allows blood to penetrate from the aortic lumen to the media. It's usually preceded by some wall degeneration or cystic medial necrosis. This creates a false lumen. It can propagate either antegrade or retrograde. The most important risk factor is hypertension, which occurs in most patients, and pain is the most common presenting symptom. This is a classification scheme for aortic dissection. Of course, all of our aortic pathologies have their own classification schemes to memorize. Type 1, aortic valve to the bifurcation. Type 2, from the involving the ascending aorta. Type 3, from the left subclavian to the diaphragm. The important caveat is that aneurysms that occur proximal to the left subclavian artery, which should be operated on emergently. There's a 20% mortality of these types of aneurysms in the first 24 hours. These are generally managed by cardiac surgeons. For type B dissections, which extend from the left subclavian down, medical management is generally appropriate for uncomplicated dissections that haven't caused consequences of rupture or organ ischemia. Blood pressure management is key, as well as pain control. Some of the indications for intervention with type B dissections include malperfusion syndromes of visceral organs, kidneys, extremities, impending rupture, intractable pain, and uncontrolled blood pressure where the patient is not able to be managed medically. As I mentioned before, there's really no indication for endovascular repair in uncomplicated type B aortic dissections. Just brief discussion of other types of aneurysms other than aortic aneurysms. The risk of femoral or popliteal aneurysms generally is more a risk of thrombosis and embolism. The rule of thumb is that as you go further into the periphery with these aneurysms, the risk becomes more of thrombosis and less of rupture. They can be associated with abdominal aortic aneurysms, which exist in about half of people that have femoral or popliteal aneurysms. On the other side, patients that have abdominal aortic aneurysms, only about 10% have femoral or popliteal aneurysms. Renal aneurysms can occur as well. Their main risks are of rupture or in some patients of hypertension. And similarly, splenic artery aneurysms are the other common type of aneurysm where the main risk is of rupture. Splenic artery aneurysms can occur in women, often of childbearing age, and typical patient presentation on exams is of a pregnant woman who presents with severe abdominal pain and blood loss. Rupture of a splenic artery aneurysm is a sort of catastrophic complication in pregnancy, and in a younger woman of childbearing age, you want to consider repairing those aneurysms. How do we repair them? For femoral popliteal aneurysms, electively, some sort of bypass and aneurysm exclusion. In the urgent setting, if the aneurysm has thrombosed, you want to consider lysing the aneurysm to improve the outflow, followed by some sort of bypass or endovascular repair. Renal aneurysms are treated often with bypass. They can be complicated, especially if they're out towards the hilum and might require some sort of ex vivo reconstruction. And then splenic artery aneurysms can be ligated. Nowadays, we can often embolize them or treat them with stent grafts as well, depending on their location. And in worst case scenarios, you can do a splenectomy. So some of the concepts of popliteal aneurysms, they're an important cause of acute limb ischemia, and always good to keep in the back of your mind if someone presents with an acutely thrombosed popliteal artery. They occur mostly in men. In about half of patients, they're bilateral, so you want to look for them on the other side if you find one. There's an abdominal aortic aneurysm in about half of patients that have femoral or popliteal aneurysms. The general threshold for treating these is 2.5 centimeters. It's what's described for the boards. In reality, we tend to start thinking about fixing them around 2. Vein bypass is the board answer, first choice for bypass. Many of us will use prosthetic in the current age, especially for a shorter bypass. But for the purposes of the exam, the vein is your first choice. You want to ligate and exclude the aneurysm. In a patient that presents with acute thrombosis and they either have a known or found popliteal aneurysm, you want to think about lysing open that artery to try to improve the outflow first. So next topic briefly, mesenteric ischemia. The key to the sort of diagnosis and treatment of mesenteric ischemia is understanding the arterial circulation to the intestines. Mesenteric ischemia can present acutely as an acute occlusive event, which is typically a thromboembolism, most often to the superior mesenteric artery. It can be a chronic occlusive event that are more chronic symptoms. This is an issue of chronic arterial disease. Typically, you need at least 2 of the 3 main mesenteric vessels to be severely stenotic or occluded to cause chronic mesenteric ischemia. There can be non-occlusive forms of mesenteric ischemia that occur in critically ill patients that are hemodynamically unstable on vasopressors. And then finally, patients can present with mesenteric venous thrombosis that in late stages can cause an insidious type of acute to subacute presentation of mesenteric ischemia. So, presentations and signs and symptoms. In the acute setting, a sudden onset of pain out of proportion to physical findings is the typical presentation. In the chronic setting, patients often have postprandial pain, avoidance of food, weight loss, as a presentation. Evaluation really depends on the presentation of the patient and what you are suspecting. In the acute setting, evaluation by CT scan is probably the diagnostic test of choice. Duplex is not very useful in the acute setting because those patients can be difficult to examine. You can't press on their abdomens. It can be useful in the chronic setting in someone in whom you suspect mesenteric ischemia, especially if your lab is accustomed to doing these types of studies. CT angiogram is probably the test of choice. In the old days, we used to do formal angiography. If you are doing formal angiography, you want to make sure you get a lateral aortogram because you won't really see the origin of the mesenteric vessels on an AP aortogram. So treatment, again, depends on the presentation and the cause. For acute occlusive mesenteric ischemia, this is almost always an embolus. You want to do a thrombectomy. The concept of second look laparotomy comes up, and we'll talk about that in a second. In terms of chronic occlusive mesenteric ischemia, some sort of bypass or endovascular treatment is appropriate. For non-occlusive mesenteric ischemia, the mainstay of treatment is supportive and to try to improve the hemodynamic status of the patient, get them off the pressors. Occasionally, in very rare circumstances, really, you can put a catheter into the mesenteric vessel and infuse a vasodilator. And then anticoagulation is the mainstay of treatment for mesenteric venous thrombosis. In, again, very rare circumstances, you can consider thrombolysis. So we'll talk now about lower extremity arterial disease for the next sort of half of this discussion. We're going to go through the concept of what an ABI is, talk a little bit about acute limb ischemia and what causes it, chronic limb ischemia and peripheral arterial disease, treatment options, and then a little bit about compartment syndrome, amputations, and diabetic foot problems, which are a frequent sort of issue that everybody encounters, general surgeons and vascular surgeons. So we'll start with a question. A 62-year-old woman was admitted with acute left leg weakness and pain. She has no palpable pulses in the left lower extremity, and her foot is pale with decreased sensation and weak motor function. What is the most appropriate treatment? A, angiogram and thrombolysis. B, anticoagulation with heparin. C, primary amputation. D, femoral thrombectomy. E, tibial angioplasty. And the correct answer is D, femoral thrombectomy. This is a patient with a threatened limb, already losing neurologic function, trying to get the leg revascularized rapidly is the appropriate answer. So in a patient who presents with acute or chronic limb pain, the physical exam is an important part of diagnosing the problem. You want to do a full pulse exam, including femoral, popliteal, and pedal pulses. This can give you a sense of where the occlusion is occurring. Examination of the foot. Chronically, patients with ischemia may have thin, hairless, dry skin, brittle nails. They may have some small chronic wounds or ulcers, particularly on the feet. And then the idea of dependent rubor or pallor with elevation, where their vascular bed is maximally vasodilated because of occlusions, and the dependent rubor is dependent because gravity leads to increased blood flow through this maximally dilated vascular bed. The pulse exam can inform you of the location of the obstruction, as we discussed. So if you have no femoral, popliteal, or pedal pulses, this is likely a more proximal obstruction. And then depending on which pulses are palpable and where you lose them, you can diagnose the location. Some of the causes of these types of these locations of obstructions are important to consider, especially if you suspect popliteal occlusion. In the acute setting, you might want to consider popliteal aneurysm. The ABI is an important part of a physical exam as far as we're concerned. This is done by putting a blood pressure cuff around the ankle and measuring the blood pressure in the leg. So the definition of ABI is the systolic pressure at which the Doppler signal reappears, divided by the brachial systolic pressure. You want to use the higher of the two brachial pressures in terms of the arms. The advantages are that it is objective. You can repeat it. You don't need a lot of equipment for it. There are some limitations of the use of the ABI in patients with severe calcified disease where their vessels are not compressible, or in patients that are not tolerant of compression, or in whom you don't have a large enough blood pressure cuff for their leg. This may not be an accurate measurement. A normal ABI is more than 1. An abnormal ABI we define as less than 0.9, and then we have this sort of fuzzy area between 0.9 and 1. Patients that have claudication typically have ABIs of 0.5, 0.4 to 0.9. With more critical limb ischemia, the ABIs are less than 0.4. And then tissue necrosis typically occurs at an ABI of less than 0.2, although depending on how they have gotten a wound, tissue necrosis can occur with ABIs that might be a little bit higher than that. So just to talk briefly about acute limb ischemia, the most common cause is an embolus, typically from atrial fibrillation, but other situations where you might get an embolus is from heart related to a myocardial infarction or aneurysm, or in somebody who has had a cardiac catheterization or angiogram and had catheter manipulation across their vessels. Emboli tend to lodge at bifurcations. Most emboli are femoral, and they can cause profound ischemia in somebody who otherwise has normal vasculature because they have not had the chance to develop collaterals. Acute thrombosis of arteries can also cause acute ischemia, although this tends to be a little bit more insidious on presentation. Often this occurs in the setting of chronic disease where there's already a stenosis and then the vessel thrombosis. There are often some collaterals already present, so the presentation can be a little bit slower over hours to days as opposed to hours. Unfortunately, only about 40% of patients with acute thrombosis on top of chronic disease give a prior history of something like claudication, often because these patients aren't active enough to result in some of these symptoms. So here are the most common sites of arterial emboli in this diagram. Again, as we mentioned, the most common site is common femoral, followed by popliteal. Assessing the viability of tissues in acute limb ischemia is very important. You want to look at the neurologic function in the foot, sensation and motor function, as well as the appearance of the foot at later stages with irreversible ischemia. You can have fixed staining of the tissues, muscle rigor, and loss of venous signals as well as arterial signals in the foot. The practical approach towards assessing the severity of limb ischemia is that cyanotic skin or weakness, neurologic weakness require emergency intervention. So this is just the 5 Ps that we all learned in medical school of acute limb ischemia to consider when patients present with these symptoms. And they do go in order of severity. So pulselessness is probably early. Paralysis is one of the latest findings. And so the algorithm for acute limb ischemia is generally goes like this. The first thing you want to figure out is the status of the limb, whether it's viable, threatened, or in occasional extreme cases, a non-viable limb. You want to establish your diagnosis, and there's in most circumstances with acute limb ischemia, your physical exam should be able to tell you your diagnosis. And then you want to decide what kind of intervention to do, either open surgical intervention versus endovascular intervention with thrombolysis. And then you have to make the decision about what to do after you have reperfused the patient, whether the patient needs a fasciotomy or not. So in terms of your diagnosis, as we discussed with the physical exam, your pulse exam should give you your location of occlusion and your diagnosis in most situations, along with a history of something like atrial fibrillation or a patient who is in atrial fibrillation at the time that you examine them. A couple sort of caveats in situations where you should consider additional imaging. Occlusion at the level of the popliteal artery, as we have mentioned before. If the patient has a popliteal artery aneurysm that has thrombosed, you won't be able to thrombectomize this because it's an aneurysmal vessel. So you want to think about getting some sort of imaging to diagnose this if this is the level of occlusion. And if they do have a thrombosed popliteal artery, you should consider thrombolysis in these patients to try to get the outflow as open as you can. Oftentimes you're not able to open up a lot of the outflow vessels because this is a sort of ongoing problem as thrombus develops in popliteal arteries, but it's important to think about trying to get some outflow open. The axillary artery is another location. If you don't have an axillary pulse on exam, you want to consider other imaging. You want to avoid blindly thrombectomizing proximal to the axillary artery because of the cerebrovascular vessels that come off at these levels, where you want to avoid embolizing into the vertebral artery in particular. So this is another situation where you should consider some CT angiogram or other kind of imaging prior to embarking on an operation. So how do we treat acute limb ischemia? If someone has an immediately threatened limb, that's probably one of the most important things to diagnose. Then thrombectomy and embolectomy is the treatment of choice. You want to expose the artery. Typically, we start at the femoral level. It's the easiest exposure. Do a balloon embolectomy and then assess inflow and outflow. The decision of whether you need additional intraoperative imaging is a clinical decision, often based on the pulse exam. If you get a pulse returned in the foot, typically I don't do additional imaging in that setting. And then if you can't get inflow or outflow, you should consider some kind of bypass to restore those. And then the final decision is whether or not you need to do a fasciotomy. So this is just some thrombectomy catheters and a diagram of a femoral thrombectomy where you isolate the vessels. The direction of the arteriotomy is another thing that sometimes comes up, typically in a patient with an embolus who has a normal soft vessel. Otherwise, you can do a transverse arteriotomy. If someone has a lot of disease in their vessel, those are the situations where you more commonly will do a longitudinal arteriotomy and then have to patch it. It's the disadvantage of doing it longitudinally. In most emboli, the vessel's soft and patent, and you should be able to get away with a transverse arteriotomy. You pass your balloon catheter, remove the clot, pass it in segments. In somebody who has a marginally threatened limb, you can consider doing thrombolysis. This is a patient who does not have motor dysfunction yet. Once they have motor dysfunction, we consider that an immediately threatened limb. So the way to do this is to get a catheter in place at the level of the thrombosed vessel and then infuse thrombolytic agents. And typically the agent used today is a form of TPA. You want to give a pulse bolus at the time of the procedure and then drip the TPA in over a period of time, usually 12 to 24 hours, and then repeat the angiogram. You can adjust the position of your catheter. You can do angioplasty if you feel you need to. The biggest drawbacks are the risk of bleeding with the thrombolytic agent, as well as the fact that this needs time to work. It does not work immediately. So it's not an appropriate technique for somebody who has an immediately threatened limb. In terms of monitoring after thrombolysis, we monitor fibrinogen, we monitor PTT, and when the fibrinogen is less than 100 milligrams per deciliter, there's a higher bleeding risk. Often we'll hold the TPA or stop it. There's some risk of embolization with TPA, and this often occurs at some point during the treatment with TPA. The treatment's usually to continue doing the lysis, and eventually that portion of the clot is also addressed with the lytic agent. Absolute contraindications to thrombolysis, important to know: any active internal bleeding, a recent stroke, recent spine surgery, intracranial neoplasm, uncontrolled hypertension, any kind of clotting disorder, allergic reaction, and then the relative contraindication to consider is the patient cooperation that's required to do these kinds of procedures. The patient does have to lie still for a prolonged period of time on bed rest. So finally, we'll talk briefly about compartment syndrome and fasciotomies. Extremity compartment syndrome is basically an increase in tissue pressure in a non-expansile space. This can occur from either traumatic injury or reperfusion injury, which is what's typically seen in the vascular situation. The consequences can be muscle infarction, rhabdomyolysis, and then, of course, neurologic dysfunction leading to contracture. The pathophysiology of compartment syndrome starts with ischemia and reperfusion. The reperfusion leads to inflammation, increased permeability, disruption of cell membranes. This leads to a lot of cell swelling and interstitial edema, and this increases the compartment pressure both by increasing the edema of the tissues as well as increasing the venular pressure, which decreases the outflow. Ultimately, as the compartment pressure increases and above the level of capillary pressure, nutrient blood flow stops, and this results in tissue necrosis. So the sequence of events with compartment syndrome, nerve dysfunction tends to occur first. Unmyelinated nerve fibers are affected first, and one of the earliest signs of compartment syndrome is numbness in the first web space. Muscle becomes eventually tense, painful, and pain with passive motion is another hallmark of compartment syndrome. And then measuring compartment syndromes is a bit hairy. In general, the principle is that if you suspect compartment syndrome, you should do something about it. But here are some of the definitions of compartment pressures, and if you do use them in your institution, how to use them. This is a diagram of a fasciotomy. There are different ways to do fasciotomies, but for the purposes of the board exam, 2-incision, 4-compartment fasciotomy is the right answer for any patient in whom you suspect compartment syndrome. You want to address all 4 compartments in the leg: anterior compartment, lateral compartment, superficial posterior compartment, and deep posterior compartment. The deep posterior compartment is where a lot of all of the vessels are located. The anterior compartment is probably most commonly affected by compartment syndrome. So in terms of acute limb ischemia and postoperative management, one of the important things to do is to prevent further episodes of embolization. So once the acute embolus is treated, you want to look for the cause. Most common cause is from the heart, so those patients should get some sort of echocardiography, probably most appropriately TEE, to look for a cardiac cause. If you don't find one there, you can consider doing CT scan of the chest and the abdomen to look for other causes. The main treatment for cardiac source emboli is anticoagulation, because there's a continued annual risk of embolization after one episode. If the patient has an aneurysm somewhere, you want to consider repairing and excluding that. And then sometimes we'll see emboli from ulcerated plaques in different locations, and the treatment of this is individualized. If the plaque is generally located in an area that we can readily repair, especially with an endovascular treatment, then we think about repairing it, putting a stent across it. Antiplatelet agents are the appropriate treatment in a patient who is embolized from a plaque. We'll talk a little bit about chronic arterial disease for a little bit. Question to start. A 72-year-old man complains of constant severe pain in his left foot. The pain is more severe at night. He has a long history of diabetes and smoking. His left ankle brachial index is 0.3. What is the most likely explanation for this patient's foot pain? A, intermittent claudication. B, diabetic neuropathy. C, restless leg syndrome. D, dry gangrene. E, ischemic rest pain. And the correct answer is E, ischemic rest pain. Risk factors for chronic limb ischemia. This occurs related to atherosclerotic disease. As with all other atherosclerotic disease, smoking is the most important risk factor. Family history is an indirect risk factor as well. Diabetes increases significantly the risk of amputation in patients. Hypertension is a risk factor, as well as hyperlipidemia. So peripheral arterial disease, or PAD, as it's come to be known, can range from mild to severe. The symptoms vary depending on its severity. Claudication, typically occurs with moderate arterial disease. Claudication is cramping in major muscle groups with exercise or walking. Ischemic rest pain tends to occur with severe arterial insufficiency. Rest pain is pain typically across the transmetatarsals or in the ball of the foot at rest that improves with dependency. So it occurs when the leg is elevated, and it improves with dependency. It tends to occur because the vessels are maximally vasodilated at this point, and because of the severity of the arterial insufficiency, the blood flow is really dependent to a great degree on gravity. So gravity helps it, and the pain improves. And then gangrene is the sort of most severe symptom of arterial insufficiency. One of the important principles of peripheral arterial disease is that the medical treatment of arterial disease is critical because these patients are at very high cardiovascular risk. PAD increases all-cause mortality by 3. It increases significant increase in risk of death from coronary disease. And basically, the presence of peripheral arterial disease is an equivalent risk to the heart of having had a previous cardiac event. So this is why we really emphasize the medical treatment of peripheral arterial disease first and foremost, even before considering interventions and things to treat patients' symptoms. Another example of risk of mortality with PAD, sorry, the labels sort of moved a little bit here, but this is the curve of a control mortality and survival over time. This dark black line is claudicants, and then the dotted line is patients with critical limb ischemia who have a significantly decreased survival. Patients with critical limb ischemia have only 50% of them will be alive 5 years after their diagnosis. And these deaths are typically from coronary disease. So diagnosis of chronic limb ischemia, again, the symptom can help inform us of the disease level. Patients that present with thigh and buttock claudication typically have aortoiliac disease. Patients with calf claudication typically have femoropopliteal disease. And patients with limb-threatening ischemia typically have either distal disease or multi-level disease. In diabetic patients, again, limb-threatening ischemia may occur with lesser levels of atherosclerotic disease. And there are a few subgroups of patients with poor collateralization that also may get critical limb ischemia early. So how do we diagnose it? We have a number of different tests available. that all have advantages and disadvantages. They're listed here on this slide. In general, duplex imaging is a good first test for peripheral arterial disease in somebody with symptoms or with an abnormal pulse exam. Its use is limited because it can't clearly define anatomy in most situations, especially in the setting of aortoiliac disease, where this segment of the vasculature is more difficult to image with ultrasound, although it can be done. The duplex can be combined with arterial Doppler studies that help us to get the ABI measurement in a precise way, so we can use both the imaging studies as well as ABIs to help us diagnose. Additional imaging with things like CT angiogram, MRA, or a formal angiogram are typically reserved for patients in whom you're planning to do some sort of intervention, or in someone whom you have trouble making a clear diagnosis, but most commonly it's a planning type of study. CTA versus MRA is often an institution-dependent decision, depending on what kind of technology and software you have available to you at your institution. In general, intra-arterial angiography we now reserve for situations where you are planning to do some sort of intervention. You do not want to do a formal angiogram for the purposes of diagnosis alone. In terms of board questions, sometimes this is a question that's asked. Some of the general concepts of peripheral arterial disease and chronic limb ischemia. For mild disease, in general, exercise, smoking cessation, medical treatment, including management of hypercholesterolemia and hypertension is important. Smoking cessation is essential in terms of managing these patients. There has been a benefit shown to silastazole or Platol in the treatment of claudication in terms of increasing walking distance. So this can be used in patients with claudication. Patients with limiting claudication, you can consider endovascular intervention. And in general, patients with critical limb ischemia typically need surgical revascularization. The decision of what type of procedure to do is also somewhat dependent on the location of the disease. Generally, more proximal disease is a little bit more amenable to endovascular treatment if you can get across the lesion with a wire. Iliac arteries do pretty well, and the primary mode of treatment is a balloon or stent. In the superficial femoral artery, depending on the symptom presentation, which often is a result of the extent of the disease in that particular vessel, you can consider endovascular treatment for claudicants. The general principle is that most patients with tissue loss will end up needing some sort of operative treatment. This isn't hard and fast, especially if the disease is at the level of the superficial femoral artery with good outflow and you're able to get across it. With tibial disease, usually the board answer is that those patients will end up needing a bypass. We do endovascular interventions now for some tibial disease in some groups of patients, but overall, the tibial endovascular interventions tend to have significantly lower patencies. Types of treatment. Patients that have aortic occlusion will often typically need an aorta bifemoral bypass. These are often difficult to get across endovascularly and difficult to treat because of the anatomy and the location of the occlusions. And somebody who is high risk for an aortic surgery, an axillobifemoral bypass can also be considered, a bypass from the axillary artery to both femoral arteries in patients with aortic occlusion. And then femoral endarterectomy is a surgical option for patients with significant common femoral disease leading to symptoms. This is another location that's not well treated endovascularly because of the branch point of the superficial femoral artery and the profundifemoris artery here. Endovascular treatment isn't appropriate in this location. Some of the limitations of endovascular treatment are that the plaque remains in the artery and can reform. Technical failures can happen, particularly related to dissection of the artery. Angioplasty depends on dissection of the artery to break up the plaque, and if that dissection propagates, you can have blood flow issues. It doesn't work as well in smaller vessels. There are often mechanical stresses, so especially if you end up putting stents in locations where there are these stresses, that can result in failure of the stents. There are certain areas that we typically do not stent. The common femoral artery, as I mentioned, related to the endarterectomy, is one of those areas because of the importance of the profunda and the SFA in this location. We don't want to risk either of those branches, so that's generally treated operatively. Some people also do not typically like stenting the area of the popliteal artery, although stents and technology are getting better to allow us to treat these areas, and things such like atherectomy can sometimes be used in these locations. But putting a stent across a joint is typically not always the best option. In terms of durability of endovascular treatment, as we talked about, it works very well for more proximal disease and works not as well for distal disease. And again, these are patency estimates from different locations of endovascular treatment shown in red versus surgical treatment shown in green. Overall, the patencies for more proximal disease, although still better for an aortofemoral bypass, are acceptable. As we get further distal in the circulation, the patencies of endovascular treatment are not as good. So what are the surgical options for treatment? The primary surgical option is some sort of bypass. It's a durable procedure in general. You can treat multiple levels of disease. You can treat small arteries. The drawbacks are that it's a higher risk procedure than an endovascular procedure, and the wound complication rate is significant in these patients, and the incisions that are necessary do impact the recovery. General principles of bypass surgery: vein is typically better. The shorter the bypass, the better. There's really no outcome difference in different configurations of use of autologous conduits, so whether we reverse it versus use it in situ. And as I mentioned on the last slide, the wound complication rate is critical, so it's really important to pay meticulous attention to how you do your vein harvests to try to prevent these. Again, it's more common in diabetics to get a wound complication as well. And then the idea of extra anatomic bypasses is important to keep in mind in somebody who is a high-risk patient for a usual anatomic bypass. This is typically used in the setting of aortoiliac disease, where you don't want to operate on somebody's aorta because of their risk. It's better tolerated and less risky, but its durability is more limited than the anatomic bypass. Bypass grafts can fail. The time frame of the failure is related to different causes typically. So early graft failure, which we typically define as within 30 days, is most commonly a technical error, and when it's not a technical error and we can't find a technical error, it's related to some sort of hypercoagulable state in patients. Early sort of intermediate graft failure in the 1 to 24 month range is related to intimal hyperplasia. And then late graft failure is typically related to progression of atherosclerotic disease. Bypass grafts in the lower extremities, we typically survey. The exact interval at which we survey them varies from surgeon to surgeon. I tend to do a post-op, and then every 3 months for the first year, and after that every 6 months. But the surveillance exact time periods can vary. Another question: a 65-year-old man has dry gangrene involving the 3rd through 5th toes. He is non-ambulatory and has a severe knee flexion contracture. He has an ABI of 0.5. What is the most appropriate amputation? A, ray amputation of toes 3 through 5. B, transmetatarsal. C, below knee. D, above knee. E, hip disarticulation. The correct answer is an above knee amputation. So we perform lower extremity amputations for a number of different disease processes. Diabetic complications are probably the most common reason. Infection with ischemia from other causes follows. Ischemia is probably explains 10% of amputations that we perform without ischemia, without infection. And then osteomyelitis, trauma, and other causes. Some of the general considerations in patients who you're considering an amputation in. First and foremost, think about limb salvage. Evaluate the patient, see if they are a candidate for revascularization, both from a clinical standpoint as well as an anatomic standpoint. Some of the contraindications to limb salvage include a non-functional limb, patient that does not ambulate, fixed contractures, extensive tissue loss and gangrene that may not be able to be salvaged despite revascularization. And then, in a relative sense, dementia, depending on how severe the dementia is, an organic disease. This may be a condition in which you can't put a patient through a prolonged operation like that. And then there are situations where we are emergently asked to do amputations, including an uncontrolled or ascending infection. Typically, in these types of situations, you want to think about a two-stage amputation where you do one stage and leave the wound open. And then come back a few days to a week later to close the wound. Types of amputations have different energy requirements on the patient when they're completed. Typically, a digital amputation has minimal energy cost to the patient compared to an above-knee amputation, which can increase the energy requirements up to 100%. It's hard to predict whether an amputation is going to heal or not in general. There are some rules of thumb that we use. Ankle pressure is one measurement. If the ankle pressure is less than 40, a below-knee amputation is unlikely to heal. Toe pressure is another measurement we use for a patient undergoing a toe or foot amputation. Rule of thumb, if the toe pressure is greater than 45, that toe amputation should heal. Some people use transcutaneous oxygen. This is a sort of finicky measurement system of oxygen in the skin. Again, the rule of thumb, if you're using this, is greater than 25 millimeters mercury pressure on the dorsum of the foot, suggests that you should be able to heal a below-knee amputation. In general, just to show you how not good we are at predicting whether amputations are going to heal, somewhere up to 25% of people that have a BKA will end up needing a revision to an AKA. So this is what happens to people after a BKA in the early setting. Somewhere around 75% heal, either by primary or secondary intention, but a full quarter may need additional procedures or may not even survive the original procedure in the perioperative period. After 2 years, only 40% of these people have full mobility, and you can see there's a 30% mortality at 2 years, patients that have had an amputation. So one of the that's probably one of the most interesting statistics about amputations is that the 5-year survival after an amputation is very poor, especially after an above-knee amputation. 5-year survival is 37% compared to 85% for age-matched controls. A higher risk of DVT and PE. Joint contractures tend to occur after amputations because people don't use or move their limbs. And then ulcerations can occur related to either pressure or marginal perfusion. Neuromas are another complication of amputations that can occur and result in significant localized pain. And then phantom pain is a significant problem in some patients. It's a central pain syndrome. So we'll just end with talking a little bit about diabetic foot problems. We'll start with a question. What is the preferred incision for draining a midfoot abscess in a patient with diabetes? A, longitudinal plantar, B, transverse plantar, C, longitudinal dorsal, D, transverse dorsal, E, cruciate. The correct answer is longitudinal plantar. So in patients that present with diabetic foot ulcers, just to talk about some of the general concepts, diabetes results in a 15 to 20% more increased likelihood of needing an amputation. In someone that has a lesion on one foot, there's a 50% risk of developing contralateral lesions. And anywhere from 25 to 70% of amputees will need a contralateral amputation within a year. Some of the contributors in diabetes to the issues with wounds are neuropathy in the diabetic, ischemia related to arterial disease, as well as small vessel disease, and infection. In terms of clinical assessment, it's important to consider the severity of the infection that you are dealing with, whether or not that limb can be salvaged, and then whether there is associated ischemia or not. Important considerations. It's difficult for us to determine whether or not there's adequate blood flow to heal a wound in a diabetic patient. And another important consideration in terms of patients with peripheral arterial disease and diabetes is that you might need a lot less reduction in blood flow to result in a non-healing wound in a diabetic patient. So in any diabetic patient that has tissue loss and does not have a palpable pulse, we would generally consider some sort of arterial intervention prior to sort of complete treatment of a wound in those patients. The level at which we would consider intervention in terms of the degree of arterial disease is probably, you probably don't need as much disease to result in wounds because of the other factors that contribute to non-healing of wounds in diabetics. Diabetic neuropathy is an important contributor to pathophysiology of diabetic wounds. This, you lose protective sensation. There's a motor component to diabetic neuropathy that contributes to muscle wasting and leads to deformity of the foot that can put undue pressures on points on the foot that can result in wounds. And then there's loss of autonomic function as well that puts the skin at higher risk for ulceration. Charcot's arthropathy is a classic diabetic foot deformity. It's a fracture dislocation process of the foot and ankle. It's due to sensory and autonomic neuropathy. These patients often have palpable arterial pulses. The typical structure of the foot is this rocker bottom foot that occurs and puts undue pressures on different points on the foot. And can often predispose to diabetic ulcers and infections. In terms of patients that present with infections, you want to assume that they have resistant infections until you have cultures proving you otherwise. Outpatient antibiotic spectrum is often a cephalosporin and Bactrim. An inpatient antibiotic typically involves broad spectrum antibiotic coverage. Need to continue the coverage for approximately 2 weeks until the cellulitis is resolved and the wound looks completely clean. In some patients with osteomyelitis, you may need additional surgical debridement and prolonged antibiotics for 4 to 6 weeks. The type of surgery that's done for diabetic foot infections, these infections can be severe, and often the degree of infection beneath the tissues and beneath the skin is more severe than is often apparent at the skin level. If there's crepitance, tenderness in the foot compartments, or evidence of an ascending infection, you want to bring the patient to surgery urgently. And when you explore the plantar compartment, often these infections spread along the tendons, and so you want to use longitudinal incisions and extend the incisions for the entire length of the abscess. You want to conserve viable tissue, but wide drainage is an important principle for diabetic foot infections. That's the end of the morning presentation, and then we'll have another session. You guys can take a break if you want. Yeah. Yeah, so that's so the question was about follow-up after endovascular AAA repairs and what follow-up is appropriate. So in general, the key answer for the purposes of the exam is that you need some follow-up at regular intervals, at least yearly. It really depends on the lab and how comfortable your ultrasound lab is at doing ultrasounds to look for endoleaks and examine aneurysm size. So if you have a good lab, in our practice, we tend to use ultrasound a fair amount. So for the initial study, we'll get CT scans to look at the aneurysm, and I'll often get an ultrasound at the same time to make sure they're comparable, and then we'll alternate ultrasounds and CT scans, or get ultrasounds for 2 years and then get a CT scan. Especially after you've followed the patient for a year or two and they've been stable, you can probably get ultrasounds more frequently. The key is to examine the aneurysm size and to look for type 1 endoleaks. So as long as your lab is able to see those juncture points well, I think an ultrasound will suffice. We typically aren't going to recommend interventions for more subtle endoleaks unless the aneurysm is growing.